Asmita, shall we start?
Yes, sir, you can start.
Okay. So good evening to all of you. As usual, we'll start with the short case first. Unfortunately, today I don't have very fantastic cases, but I can show 3-4 interesting short cases. So I'll start by screen. Okay, just one. Is my screen visible?
Yes, sir, it's visible.
Yeah. This is a story of a 54-year-old lady who was diagnosed with carcinoma breast, for which she had undergone surgery followed by radiation 2 years back. Since then, she was noticed to have severe imbalance in walking, incoordination of the upper limbs, and dysarthria. According to the bystander, the complaints remained the same without any improvement or worsening. No history of any cognitive impairment. No history of any headache or vomiting. So this is the video of the patient.
എവിടെ വീടമ്മയുടെ അമ്മ വല്ലതും കഴിച്ചോ രാവിലെ? ശരി മെനുവൻ ഞാൻ പറഞ്ഞതുപോലെ അമ്മ ചെയ്യണേ. അമ്മ ഇങ്ങോട്ട് നോക്കിക്കേ, കുഴപ്പമില്ല. അമ്മ ഈ വിരലിലോട്ട് നോക്കമ്മ, ഈ പാനിലോട്ട് നോക്ക്, അല്ല ടോർച്ചിലോട്ട് നോക്ക്. ഇനി അടുത്തോട്ട് നോക്ക്.
Ocular movements are normal, but she had not been diagnosed, which will be visible little more in the later part of the video.
ആന്ന് പറഞ്ഞ്
normal.
അങ്ങോട്ടും ഇങ്ങോട്ടും തള്ളിക്കമ്മ. ഒരു പിടിച്ചോ, ഒരു
മിനിറ്റ്.
അങ്ങനെയല്ല, എൻ്റെ കൈ ഒന്ന് പിടിക്കാൻ നോക്കേ. ഇതൊന്ന് മുറുക്കി.
The motor power was normal.
വിട്ടോ, കൈ ഒന്ന് പൊക്കിക്കമ്മ.
Severe incoordination of the upper limb. Upper limb.
ഇനി അമ്മ എന്നെ നോക്കേ. ഇനി എൻ്റെ വിരലിൽ തൊടാൻ പറ്റുമെന്ന് നോക്ക്.
Asking to touch my finger, which she couldn't do. It brings both upper limbs brings far apart from my hand.
ഇവിടെ നോക്കമ്മ, ഇവിടെ.
Look at the eye movement. She has got not been diagnosed looking towards the left side.
ഇങ്ങോട്ട് നോക്കമ്മ.
Much less on looking to the right.
ഇവിടെ നോക്ക്. Did you get this diagnosis? Okay.
I'll show once again. Now you can make out the dot being diagnosed looking towards the left side.
വിരല് നോക്ക്, ഇവിടെ നോക്കമ്മ. എൻ്റെ വിരല് കാണാം അമ്മയ്ക്ക്? ആ വിരലിൽ തന്നെ നോക്കിയാൽ മതി. എൻ്റെ വിരല് വിറങ്ങും നോക്കല്ലേ, എൻ്റെ വിരല് നോക്കി. ഈ വിരല് അതുപോലെ ഈ വിരലിൽ നോക്കമ്മ.
It is there on the right side, but much less compared to that of what you need to the left side.
മുകളിലോട്ട് നോക്കമ്മ, താഴെ.
There was no nystagmus looking up and down. The lower limbs motor power was normal.
പൊക്കിക്കേ, മതി. വിട്ടോ. പാദം മുകളിലോട്ടെടുത്തേ. മുകളിലോട്ടെടുത്തേ. മതി കേട്ടോ.
The reflexes were elicitable normally.
മടക്കം വിട്ടേ. കഴിഞ്ഞു.
The lower reflex would be slightly brisker compared to the lower. Severe incoordination in type 2. The lower limb as well. Angle jacks were normal. Panda was indefinite. Or you can call it flexor or not. But very definitely upgoing. Yeah, I think maybe upgoing, we are not sure about. Sensations were normal, so also vibrations also normal. Yeah, sorry, it was embedded in the both feet. It is present in the angle but embedded over the toes. There it is not there.
ഇല്ലേ
Joint cells was normal in the upper limb.
ഇപ്പോഴോ ആ അതേ
She is not able to feel the JPH sensation of both feet.
അറിയാൻ വേണ്ടി ശരി ഇപ്പോഴെങ്ങനെയാ അറിഞ്ഞുകൊണ്ടെങ്കിൽ അറിഞ്ഞോടാതെ അമ്മ എനിക്ക് നോക്കരുത് ഇപ്പൊ എങ്ങനെയാ ആ ഇപ്പോഴോ
She is totally making mistake as far as the joint cells is concerned.
ശരി
Sorry. So in examination, eyeball functions were normal. Non-being nystagmus when looking towards the left side. Speech, staccato speech. Severe titubation of the neck. Motor system tone power normal. TTR all normal side disc in the lower limb. Sensations impaired vibration and JPS over both toes. Severe incoordination of both upper and lower limbs. So what do you think is a likely diagnosis in this patient? Site of lesion diagnosis. Anyone?
To exclude a posterior fossa, such the vestibular cerebellum region on the left side, any posterior fossa lesion or other possibility could be a paraneoplastic in view of the old carcinoma of breast.
Okay. This happened 2 years back. She had undergone radiation. And according to them, they all followed following radiation. So do you think it could be? Yeah, yes, Bindu.
Sir, vestibular cerebellum with the somewhat of neurocerebellum also because of the slurred speech and the axial dyspepsia. Cause could be due to the radiation. Downbeat nystagmus is due to the again the vestibular cerebellum getting involved. That medullary junction, cervicomedullary junction, because of the radiation injury.
Okay, that's a good possibility. So anyone else?
But the radiation does it come onto that area? So the area of the interest for radiation, does it include the cerebellum for carcinoma of breast? It's a wide area. The area is wide above, but they usually give near the axillum.
Yeah, that's a point. It's most likely to be radiation. Okay, right. Any other possibility?
Paraneoplastic cerebellar degeneration with cervical myelopathy.
With
cervical myelopathy.
Myelopathy also. Okay.
Maybe radiation.
Maybe radiation. Okay. Any other possibility you like to make, anyone? Okay. Now, as Bindu was telling, the site of lesion is one is flocculus is involved because she has got a downbeat nystagmus. The rest of the ataxia all can be due to neocerebellar involvement because she has got severe lower limb and upper limb incoordination. And plus she has got a dysarthria, staccato speech. So all indicating that the patient has got a bilateral neocerebellar involvement. Axial involvement may be also there because of the titubation. But if both cerebellar hemisphere is involved, the patient can also have titubation by itself. Unilateral will not produce, bilateral neocerebellum can produce titubation. So it's got an impact, as you said, complete pancerebellar involvement, loading the flocculus. But my question is it all related to radiation? Is anything against radiation induced or due to lesion the posterior haloid or upper cervical quadrilobe? Anyway, what do you want now?
Paraneoplastic also can occur, sir, even if the CA recurrence and that can produce a paraneoplastic.
There is a position sense involvement, no?
Yeah, that's the point. Correct. See, that means the lesion is not confined to the cerebellum itself. That's the point. He has got impaired vibration and JPH. He's not a diabetic over the both feet. That tells a patient has got in addition a peripheral neuropathy as well. Okay, so that makes it more like a paraneoplastic syndrome. So she had in fact already that paraneoplastic profile. He came with a paraneoplastic profile which was not showing any antibody. This is the MRI taken in 2020. Shows cerebellar atrophy and calcification of the dentate nucleus. I'll show that this is the flare sequence. Tumor uppercut. This is the T2-weighted sequence. can really make out the cerebellar atrophy, the dilated fourth ventricle. I repeated the MRI, which I'll show later on. This is the initial MRI 2020 shows. Even at that time, there was mild cerebellar atrophy. So this MRI was repeated in June 2022. Now, but this month, this is the MRI. Left side showing the SWI, right side showing the prior sequence. So the cerebellar atrophy, you can see that this black thing was the calcification. I will show that once again. That picture will show once again. So this is the T2. And flyer. T2 on the left side, flyer on the right side. Liver atrophy. And this is the hypointensity in SWI, showing the calcification. Calcification of the dentatum case.
Any hypocalcemia, hypoparathyroidism, something like that?
No, that blood chemistry are also normal, but again, that one produces such a severe cerebellar ataxia like this. This is showing again calcification. You can see the cerebellar atrophy here. A CT scan was taken to find out whether there is a calcification can be seen in the CT, but it did not show any hyperdensity. Sometimes calcification can be picked up only by MRI, sometimes not in CT scan. But shows severe atrophy of the cerebellum. Now, what do you want to do now?
Nerve conduction study.
Okay, that can be done. So, in fact, I repeated the paraneoplastic syndrome, a panel, and the PCO antibody IDO was strongly positive. So, sometimes the antibody may be initially negative, may come later on. I don't know. The initial picture where they came with an antibody result that was normal. So, I repeated it, came to be as positive.
Patient is but remaining status quo.
Yeah, remaining status quo. That is all the history. But the problem is she has already got maximum cerebellar ataxia. How far can it progress?
That's right, definitely.
She cannot sit and stand. She can only cannot. That has been there. It has reached the maximum itself. So, what do you like to do in this patient? In sort of treatment?
PET scan, sir.
The PET scan. We already know the patient's got CA breast.
Immunoglobulins.
Okay. So, in fact, this sort of a thing, you should not give immunoglobulin or rituximab. Ideal thing will be either prednisolone. If not responding, go for cyclophosphamide. Because here the antigen is intracellular antigen, where the antibody, this antibody clearing agents like immunoglobulins and rituximab, etc., may not work. So, in fact, suggested that you can go for methylprednisolone followed by endoxan. I asked them to discuss it, think about the pros and cons. They did not come to follow. But they must have got said that everyone is telling no improvement will occur. Should we try this? This is the only way out. If you want, you can try, but they did not agree for the treatment. We do not know.
How does cyclophosphamide help?
Yeah, because in intracellular antigens, what you have to give drugs which are acts on the cell-mediated immunity, T-cell mediated immunity. For that, the endoxan is better than the other the surface antibodies. For example, our VJKC, NMDA, they are all surface antigens. Antibodies direct against the cell surface antigens. They respond very well to all these medications, these plasmapheresis or rituximab and methylprednisolone, etc. If it is intracellular antigen, the advocated is either methylprednisolone followed by endoxan, cyclophosphamide. That is something they don't usually respond to the other way of the usual way of treating autoimmune encephalitis.
Rituximab also works on the T cell mediated immunity, sir.
No, rituximab actually it's a B cell CD20, no?
CD20.
CD20, yeah, B cell. Okay.
Whatever given response will be poor.
Sir, one doubt, sir.
Whatever it is responsible for, even with all this medication. Yes, Bindu.
Yes, was she given chemotherapy, sir?
No, according to them, the chemotherapy was not given. I specifically asked that thing. They said they get surgery and radiation. That's all what was given.
Sir, those dentate nucleus calcifications.
I do not know how to explain that thing. I have to check whether it can occur as a paraneoplastic syndrome. I don't know.
The radiation itself can be a cause for
Calcification can be due to radiation, but as telling you, the radiation port is away from the radiation portal.
That can be just due to the.
I don't know what
Is there any diffusion restriction in the dentate nucleus, sir?
No restriction, nothing.
Even normal people can also get calcification.
Calcification is only confined only to the dentate. No other body parts are, other region, basal ganglia are not getting calcified.
So what is evidence of for peripheral neuropathy?
Because there is impaired joint sense and vibration sense. That it can explain due to posterior column itself, but only confined to the distal part.
But the knee jerks are brisk and angle.
Knee jerks are brisk. There may be pyramidal involvement, but angle jerks are just elicitable, normally elicitable. So we cannot say correctly whether it is a posterior column or a peripheral nerve involvement. So we have to do a nerve conduction study to find out that.
Her B12 are normal, sir. Vitamin B12.
B12 I did not do because such a severe cerebellar atrophy already is seen with correlating with the malignancy and everything. If strong possibilities antibody is there, then we tell PCD is the parasite. This is the antibody which causes the PCD, anti-O antibody.
Okay, sir.
So how common is after mastectomy to develop the paraneoplastic? Usually find earlier the paraneoplastic syndrome, then we diagnose.
No,
cancer.
it can develop after the tumor itself can develop. It can precede the tumor. Paraneoplastic syndrome can precede or can occur after the tumor development.
And should we evaluate for the cancer mets, sir, in this patient?
No, not necessarily, because these are not. This does not indicate the evidence of metastasis. It's only because it only indicates the malignancy underneath.
So some patients after reaching a plateau remain like that.
Yeah. Even it is. I had another patient who had a PCD that progressed and then remained plateau for years. She never totally improved, but did not worsen after a period of time.
Sir, is there any drug which can control all this tremor and all?
Not to my knowledge. People have tried carbapenem, tried maxolin. Nothing really works. Bindu, your voice was breaking.
Some heavy.
Can you repeat
Some
that?
weighted device. Sir, any weighted device is being a device like in the West, they say some weighted device has to be worn by the patient to decrease the tremor, cerebellar tremor.
No idea, Bindu.
That's for intentional tremor, no, sir. For the essential tremor, they advise to keep weight in the arms.
Okay. I do not know about that. Shall we go for another case? For 3-4 short cases. So this is a story of a 74-year-old man. He was admitted to the history of difficulty in getting up from sitting position for the last 5 months and loosening of chappals on the right foot for the last 2 months. History of paresthesia of the right lower limb below knee for the last 2 months. No root pain. So history of difficulty in getting up sitting position 5 months, loosening of the chappals on the right foot for 2 months, paresthesia of the right lower limb below knee for the last 2 months, no root pain. So this is the video of the patient. I'll only show the positive mind. Lower limb findings were confined to the lower limb. However, flexion was normal. The extension was normal. I could not break it. You can push me out without any problem. Dorsiflexion was normal. EHL is also normal. Plantarflexion was normal. Hip abduction was also normal. Abdominal reflexes were intact. Plantar was flexor. And you had mild wasting of the thigh, and right knee jack is elicitable, but less compared to that of on the left side. Right side brisk or right side decreased, but there's mild wasting of the thigh. Ankle jacks were absent. His sensation is equal, but his vibration was less over the shin. It is less compared to that on the left side. There is not feeling on the right ankle. Left he was telling correct. Distal part of both toes he is not able to tell, but the shin it is less on the right side. And he is spirax normal. He said correctly on the left side. That is impaired on the right. He made mistakes on the right. SLR was negative. And reverse SLR or the terminal stretch is also negative. There is no pain in the back. On Romberg's testing is negative. Slightly you can call positive. You are not very sure. You could stand with eyes closed. Mild swaying one. Look at the gait of the patient. This is the gait. He could stand on toes and foot, toes and heel. The situation was not that full, but still he could stand on heel. Plantar flexion was normal. He could get up from the stool. So motor system lower limb wasting is the right thigh. Tone you have to decide whether the right side is spastic or not, and the way he is walking. Motor power is normal. DTR right knee jack is diminished compared to the left side. Both ankle jacks were 1+, just elicitable. Sensory impaired vibration below right anterior superior spine is set correctly over the shin, he said is less. Severely decreased vibration over the right big toe. Impaired JPS of the right foot. SLR and reverse SLR negative. So where is the localization? What is the likely diagnosis? If you want to see the video once again, I'll show it once again.
It would be a cauda lesion, sir.
Okay, cauda. You've been confined only to one right lower limb below. First, you have to tell the roots, which are the roots affected if it is root involvement. Then you have to come to the whether it's called icon or not.
Environment L12 is involved, sir.
Okay, okay. Knee, okay, L12. L12 is affected.
Because of the wasting of the thigh with
Yeah, that is
English
L2,
lights
yeah.
the knee
Yeah,
reflex.
that is not L1, L2, L3. Okay.
L3.
Yeah.
An epiconus lesion.
Up to S1, sir. L1 to.
Okay, he has got L4 involvement, corticity is affected. But dorsiflexion, plantarflexion was good, but sensation was impaired over the right shin. And JPS was impaired over the right big toe.
Impaired
Only
vibration
the
with
right
the
toe.
preserved ankle, sir. Could be a myelopathy at the D12L1.
Yeah. Epicon.
What is it? There's no pyramidal signs as such. If you want to say myelopathy, you meant to say it's pyramidal tract is affected or not?
No, sir. The vibration is impaired, but the ankles are preserved. That could be due to myelopathy lesion. Posterior columns involved in the D12, D10 region.
No, this is only confined to the impaired JPS is only confined to the right big toe. The angle jacks are just elicitable. So can you call it as a peripheral neuropathy? Left side lower limb is normal.
Not neuropathy, sir. Due to posterior column involvement in the cords, sir. The D12L1. Myeloradiculopathy.
You mean okay. I heard the other way around. Sorry. I couldn't hear you very well. You said myelopathy and D12L1.
Yes, the right side.
And that means at the cord level, right?
Yes, sir. Yes, sir.
If it was due to a D12L1 level, you should get a brisk knee jerk on the right side. It is decreased, and you can't get the wasting. Then you have to bring down the lesion at least to L2, L3. Then again, you have to explain why there is no weakness of the dorsiflexus and plantar flexion.
A disc compressing the D12L1 region, the chorda equina, can cause myelopathy with anterior column with involvement of L3-4 in the cord.
Yeah, that's what you want to say. Okay, I understood. That means you have to say epiconus lesion causing dysfunction of the L2-3 segment and pyramidal lesion below causing your causing what? Yes, no weakness of the weakness of the dorsiflexion, plantar flexion. Only thing affected was is impaired joint cells.
Epiconus lesion with the L2, L3 radiculopathy and myelopathy involving because of spastic gait also there.
Okay, myelopathy plus two sides lesion you want to postulate.
No, epiconus lesion vanna varan padutha.
Epiconus lesion illa. Epiconus lesion how can produce spasticity? Because to produce spasticity, cortices should be spastic.
That's true.
Okay, I thought it is a simple case. Anyway, it could be interesting now. So, what do you want now? What do you want now? MRI?
Yes,
sir.
Okay, he came with MRI. This is cervical spine. Normal. Dorsal spine normal. Lumbar spine normal. So there's no cardiac lesion, no epiconus lesion.
Sir,
This is
cervical spine is not normal.
Which one?
Cervical spine is not normal, no?
It is normal.
Cord,
it is normal. Now, this is only lateral cut, not in the middle part. I'll show the axial cut later. I'll show the axial films later on. This is the one. Okay. This is the. I'll show the axial. This is cervical axial. Bringing down. All normal. Then I'll show the lumbar cord and thoracic cord. This is from below upward. Okay. Below upward, I'm taking this thing. These are quad icona roots. Come to the cornus, epicornus region, then to the dorsal cord, thoracic cord, up to the dorsal cord. So both thoracic cord, quad icona, cervical cord, all. So what do you think now?
Brain.
Brain, you did not do.
Any hip tenderness, sir? Hip tenderness.
No tenderness, no tenderness. Now let us see his gait. Now we all thought could be spasticity, no? Let us see the, before coming to that, the gait once again. Because he has no pyramidal signs as such. Okay, except the suspicious pyramidal spasticity. That is why I put Curry spasticity. I will show the gait again once again. He walks as if he's carrying the right leg. He's not lifting up the right leg as left side. That mimics like a spasticity. Okay, so he's not, the right leg is not lifting up as much as the left side, as mimicking a spasticity, correct? But actually there's no dragging of the forefoot. Okay, so I'll come to that later on. Then, so what I did was examine him once again. Now let us see. I check the quadriceps power once again. Then this is one method of examining the quadriceps. Lifting his right leg, ask him to stand on the left side. He could do that. Good quadriceps on the left side. But on putting weight on the right, the others lifting the left leg and ask him to get up on the right leg. He could not do that. That is done with the quadriceps. He was trying hard. He has got right quadriceps weakness. In fact, I was not knowing this technique of examination. So when I was in Pushpa, it is Rajit Thomas who taught me this way of looking for subtle weakness in the quadriceps. And I tried this many patients. I found this a very, very useful technique of eliciting subtle quadriceps, because quadriceps is a very powerful muscle. Unless the whole body weight can be, put on to the quadriceps, you will miss the quadriceps weakness. It's so powerful that you can easily throw you out with it when you do the conventional way of examination. That is what he did. When I examined in the bedside, he could easily push me out. But this method shows that he has got a quadriceps weakness. So in fact, that's a wasting of the thigh, the knee jack diminution, and the weakness quadriceps tell you that he has got either L2-3 radiculopathy or femoral neuropathy. But he has no adductor weakness. He has got numbness, he has got vibration decrease, and the combined was also paresthesia of the shin. So that goes more like a femoral neuropathy. Then that alone cannot explain, but he has also got impaired JP sensation of the right big toe and vibration loss. That means it is beyond the nerve. That means if something beyond the nerve, you have to think of some plexopathy you are taking. So what do you want to do now? And to confirm. Yeah, in our contest study, I have to confirm. So this is the NCS was done. This is the peroneal, this was normal. Tibial was normal. Right, the usual conduction was normal. Sensory potentials are also normal. The FA latency was normal. So in fact, we expected the only sense, see, that nerves which are testing here are the tibial con peroneal, which are not affected. You have to look for the affected nerve, that is the femoral. So look for what? Saphenous nerve, to find out whether lesion is in the plexus or lesions beyond in the roots. Okay, So you have to document the snap is absent. Then only you can say likely to be the plexus. But again, snap need not be lost all the time in plexus lesion as well as in diabetic hematopy. Snap sometimes can be, or any lumbosacral plexopathy snap, distal snap may be normal. So what else you need? Saphenous conduction was done. But unfortunately, it is absent on both sides. So I cannot be certain whether it's a technical fault or really it is absent. Again, back to square one. So it could be a mononucleus multiplex of the femoral plus some other nerve or plexopathy. So what else you want to do? And the EMG was done. EMG shows the innervation of the cortices. A typical neurogenic potential. Large amplitude potential. Is pairing frequency and decrease interference. On the other hand, from the left, that is normal. The spontaneous activity. See the potential difference between the right and the left. It's for normal potential, right side is large amplitude. The left side. Then did with the in tibialis anterior again. There is no denervation. Except one precipitation, otherwise no other denervation. Again, the potential is normal, no large potential, and good interference. The upper limb to find out in diffuse involvement of the anticonceptive disease. It's all there. Other muscles are all normal. There is no spontaneous activity, and the other potential are all normal. Good interference. I think it saves the time. Paraspinal also is. So EMG showed denervation only in the right cortices. There was other muscles were not affected. So what is your diagnosis now? So we documented element lesion, and the sensory was the distribution of the femoral nerve. So more likely for a femoral neuropathy is there. Plus that alone cannot explain the impaired JPA sensor of the big toe. So you have to think of a more likely lumbar plexopathy. So what do you want to do now?
MRI of the plexus.
MRI of the plexus to be that correct, but I did not do because already we know. I mean, otherwise we already know. Many times plexus MRI, it's not going to be fruitful because how many times brachial plexopathy or lumbar plexopathy we have an abnormality in the plexus. I have not seen anything except for the CADP type, very fine thickening. All other things are usually normal. So
Sir, is he diabetic?
No, in fact, he said he's not a diabetic. So I sent for a GTT and told to find there will be subclinical diabetes maybe there. He said he's not a diabetic. So it may be idiopathic plexitis. Plexus involvement need not necessarily diabetic, can be idiopathic plexitis.
So impaired JPS for the great toe, which nerve is involved?
Which one?
Impaired JPS for the
usually
great toe on the right side.
The big toe is the conperoneal nerve. But his sensory potential from the supraperoneal was normal. But remember that this supraperoneal we picking up proximally, not from distally. You should remember that the sensory potential in supraperoneal we picking up above the ankle. The distal involvement will not be picked up by usual snap testing. Just like, if you got a sensory loss in the little toe, but you are picking from the swirl behind the lateral malleolus, snap may be normal. In the case of distal axonopathy.
Sir, so is,
Yeah, please.
sir, so is it because of the cortisol weakness that he was just not lifting the foot?
Exactly. He has got rectus femoris also is weak. When the rectus femoris is weak, his flexion will be weak. So he'll not be able to flex when he is not flexing his thigh properly as on the left side. That is, it appears something like a spasticity. If you look at the gait, he is not lifting up his right lower limb as well as on the left side. That's probably because of hip flexion weakness.
Is he trying to lock the knee and try to protect himself?
Yeah, that's also another possibility which I can think. But in the corticeps weakness of that mild degree of locking will not be affected, will be unaffected.
So what treatment can we give, sir? Because it's already wasted.
No, not much wasted. Not much wasted. So in fact, I did not put him in steroid just because it's static for some time. I do physiotherapy and then ask him to come for some time. If it is worsening, I thought I will give him some other specific treatment.
Okay.
Because Praxitis initially occurs and start improving. No point in giving treatment after a period of time. You have to give the acute phase. This has been there for 3-4 months, 5 months. Okay. Any questions? The two things I wanted to tell because all the dragging of the lower limb is not due to human paralysis. One thing is hip flexor weakness. Second common mistake is the plantar flexion weakness, where the patient drags, but the dragging of the heel, they cannot lift up the foot, so it appears like a spasticity. At this point, I have shown before. Second point is that the way of testing the corticeps weakness, which as Rajiv has told me, this is one of the best methods to check for corticeps weakness, which seldom we do in this technique. This you should follow, because otherwise you may miss mild corticeps weakness. These are the two learning points from this case. Okay, shall I go to the next one? Okay, this is a story of a 41-year-old lady. History of imbalance while walking for the last 1 year. No other complaint, no sensory complaint, only imbalance. No upper limb incoordination, no dysarthria. Look at the patient's video very carefully.
Okay. അങ്ങോട്ട് ഇവിടെ 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 ശരി മുകളിലോട്ട് നോക്കമ്മ താഴെ ഇവിടെ നോക്കിക്കേ
No restriction of eyeball movement.
കല്യാണിച്ച് ഈ കണ്ണ് മുറുക്കി അടയ്ക്ക്
Lower canines were normal. Tone power normal in the upper limb.
മുറുക്കി പിടിക്കേ എൻ്റെ കൈ മാക്സിമം മുറുക്കി പിടിക്കുക വിട്ടോ വിട്ടോ.
The video is poor quality because taken by the bystander of the patient.
എൻ്റെ വിരലിൽ തൊട്ട് മൂക്കിൻ്റെ അറ്റത്ത് തൊട്ട് അങ്ങനെ ചെയ്ത് ഈ കൈ കൊണ്ട് ചെയ്ത്
No incoordination in the upper limb.
കൈ അങ്ങനെ നീട്ടി പിടിച്ച്
No pseudothetosis.
അങ്ങനെ പിടിച്ച് നിർത്തേ. ഈ കാല് നേരെ പൊക്കമ്മ.
Lower limb power normal,
ഇത് പൊക്കിക്കേ.
non-normal.
അങ്ങനെ പത്തി മാത്രം മുകളോട്ട് എടുക്കുക. തല തന്നെ പൊക്കിക്കേ. പൊക്കിപ്പിടി മുകളോട്ട്.
But she had lower limb incoordination. Usually was positive on both sides.
അതുപോലെ ഈ കാലുകൊണ്ട് ചെയ്ത്
That is definitely abnormal.
ഒന്നുകൂടെ ചെയ്തേ. ശരി, അവിടെ കിടക്കുന്നേക്ക്
The reflexes were normal in the upper limb.
പിന്നെ കൊടുക്കല്ലേ. മടക്കി.
Lower limbs also normally elsitable.
ഇങ്ങനെ
Ankle is also normal.
കാലിൻ്റെ ഒന്നുകൂടെ മടക്കി വെച്ച് അങ്ങനെ എത്രയും വേണ്ട അങ്ങനെ കിട്ടും.
Plantar was mute.
ഈ കുത്തുന്നതൊക്കെ അറിയാമല്ലോ ഒരു
Sensations were all normal.
ഇനി ശ്രദ്ധിച്ചോ. ഇപ്പം എന്തെങ്കിലും തോന്നുന്നുണ്ട് ഒരു വൈബ്രേഷൻ.
Vibration normal in the upper limb.
ഇപ്പോൾ ഉണ്ടോ? കാലയച്ചത് ഇപ്പോൾ ഉണ്ടല്ലോ. ഇപ്പോഴും ഉണ്ടോ? ഇപ്പം എങ്ങനെയാ?
താഴോട്ട്
ഇപ്പോഴേ
താഴോട്ട്
ഇപ്പോഴേ
മുകളിലോട്ട്
ഇപ്പോഴേ
മുകളിലോട്ട്
So JP is normal in the upper limb.
ഇപ്പോഴേ
താഴോട്ട്
ഇപ്പോഴേ
താഴോട്ട്
ഇപ്പോഴേ
മുകളിലോട്ട് താഴോട്ട്
ഇപ്പോഴേ
താഴോട്ട്
താഴോട്ടാണോ? ആലോചിച്ച്
He made
പറയാം.
some mistakes.
അറിഞ്ഞോണെങ്കിൽ അറിയണമെന്ന് പറഞ്ഞാൽ മതി.
അങ്ങോട്ട്
ആ ഇപ്പോഴോ?
താഴോട്ട്
ആ ഇപ്പോഴോ?
താഴോട്ട്
ഇപ്പോഴോ? ഇപ്പോഴോ?
താഴോട്ട്
He's made occasional mistake in the lower limb. It seems impaired. JP is impaired over both feet.
ഇപ്പോഴോ?
താഴോട്ട്
Again made mistakes in the left big toe also.
Okay.
Now look at the gait of the patient. Yes, his rhombox is positive,
കണ്ണടച്ച്
mildly positive.
കണ്ണടച്ച് കണ്ണ് തുറക്കണ്ട, വേണേൽ പിടിക്കും. സ്പീഡ് നടന്നിട്ടോ? സ്പീഡ് സ്പീഡ് വാ സ്പീഡ് വാ.
Gait is clearly ataxic gait.
അതിന് സ്പീഡ് നടക്കും. സ്പീഡ് നടക്കും. പെട്ടെന്ന്
Random walking was defective.
ഇനി മോൾ നിന്നിട്ട്
Not dorsally mildly ataxic, not very severe ataxia.
പെട്ടെന്ന് തിരിയമ്മ മുട്ടിച്ച് മുട്ടിച്ച് ചേർത്ത് ചേർത്ത് വെക്കുക.
Okay, cranial examination, motor. You have to tell me what is a cranial examination. Motor system normal in the upper limb, power normal, plantar equivocal, sensation, vibration normal both feet. JP is impaired or both toes. Patient touch was positive. So, where is a localization and what is a likely diagnosis?
Sir, in the eye movements, the adduction lag is there in the right eye, and the saccades are a little slow.
Saccades are normal, but okay, anyone, it's on the right side only. Okay, any other possibility? So what you said is perfectly right, but look at the video once again. Now I want you to look at the root of the nose, not at the eye. Again, look at the same video. Don't look at the eye, look at the root of the nose, and then you see the eyeball movement on both sides. The velocity of the eyeball movement on both sides.
ഓക്കെ, എടുത്തോട്ടെ വലത്തോട്ടെ എടുത്തോട്ടെ. ഇവിടെ നിങ്ങൾ വലത്തോട്ടെ എടുത്തോട്ടെ വലത്തോട്ടെ എടുത്തോട്ടെ വലത്തോട്ടെ അങ്ങോട്ട് ഇവിടെ 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 ഇവിടെ. ശരി, മുകളിലോട്ട് നോക്കമ്മ.
Okay, what do you find?
There is a disconjugation when the patient is looking to the left.
You are perfectly right. Left eye lags behind, but that is present on both sides, more on the right side.
Yes.
Yeah, if you can see, I'll show you once again. It is maximum on the right side, is easily make out, but look carefully. Left eye is also lagging behind when the patient makes a saccade to the right side. So it's got a bilateral adduction lag more towards more on the right side. I will say once again. Look very carefully. Look to the nose and look at both sides.
എടുത്തോട്ടെ
No, it's lagging behind. Left eye is also lagging behind.
അല്ല നേരെ ഇവിടെ നിങ്ങൾ വലത്തോട്ട് ഇടത്തോട്ട് വലത്തോട്ട്
See that?
ഇടത്തോട്ട്
Left eye is also lying behind.
അങ്ങോട്ട്
Yes, sir.
ഇവിടെ 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 ശരി മുകളിലോട്ട് നോക്കമ്മ താഴെ
In fact, that is the only, she never complained even of abnormal movement, anything. But that is the clue to say that the patient is having. What is the condition causing bilateral adduction lag?
Bilateral INOs.
And that is,
That's right, no.
if you get members, is the commonest condition.
ഓക്കെ
Okay. So on then I went and asked history of any defective, and then she's coming out of the history that 3 years back patient had defective vision and shown to the ophthalmologist that improved, that she never bothered about it. So we did a VEP which shows prolonged latency bilaterally, and MRI. This is the MRI, shows hyperintensity in the dorsal midbrain. Another dorsal finger-like hyperintensity adjoining the ventricle. This is another one, very small, not very gross finding, but see multiple, this string of beads appearance. Again, you can find the callosocaptal margin. Again, typical dorsal fingers in the ventricular surface. Spinal cord showed some hyperintensity in the upper part of spinal cord, not very convincing. This is another small hyperintensity in the cord. So that's a patient's find. So in fact, the MRI, if you one look at it, you may take it as normal unless you're very careful for the MRI finding. So with the diagnosis in your mind, you can pick up this abnormality. Otherwise, just scanning through that, this will not be picked up. You may just call it as a normal MRI. If you look very carefully, you can find the hyperintensity typical of MS. But the clinical findings are typical of MS. So in fact, this case was brought only to show to look for the adduction lag, with the patient may not complain at all. Only on examination you can find out this abnormality. So any questions?
Sir, is she on treatment?
No. She was not on a treatment. She nobody diagnosed. So we started treatment now.
But dorsal midbrain is bilaterally immodal, sir, but there is no asymmetry.
Dorsal midbrain is involved. No, see, the problem is that unless this is another cut showing. So these are all zoomed up picture I have taken specifically for it. Okay. If you when you scan the film, it may appear look normal. This cut I have taken specifically at that level and then to show you the abnormality.
Yes, sir.
When the film is given to you, then you may miss it because there's a subtle finding. Other rest of the brain is normal. I have taken only those pictures which is showing abnormality.
Was it enhancing and contrast, sir? Contrast enhancing?
This patient, no, there is no contrast enhancing lesion. Only this was there.
Okay.
Spinal lesions were there, sir, to explain the position sense loss?
Yeah. So in the lesion which you found in the spinal cord was not in the posterior cord. But she made mistakes in the joint.
Yeah. Yes, sir.
Sometimes the lesion might have occurred and then disappeared. The MRI, the lesion might have cleared sometime.
Okay.
So that means the lesion might have been there earlier, which may not be seen in the MRI. And moreover, the small demyelinating lesions in the spinal cord is easier to miss in the MRI. That is why in 3T machines and special sequences are being done to find out that lesions in the MRI, in MS patients. Okay. Any questions? Okay, then I will go for a last case today. It's a last short case. This is not a very, very interesting case, but only curious case. This 45-year-old lady has presented with complaint that the sleeve of the blouse on the right side has become very loose for the last 3 years. That's only complaint. She has no other problem. She says that this blouse is becoming very loose on the right side. She also noticed thinning on the right arm. However, there was no weakness, any sensory complaint or any pain. So this is the video of the patient. Look at the right arm. It's the left arm. The right arm is wasted. Something like some cord-like thing was there, but the skin was not taut. They are not like a scleroderma thick. The skin is not thick. It's not thick. You can see it thick. But there is following of that area there. That's it. You can again make out the thinning of the right forearm. See that following there.
Actually,
You can see the following of the middle part of the arm. Must keep it flexed. Find out the difference between the right and left. See the both right and left front view from top. There is following and wasting on the right middle. Power is all normal, reflex is normal, sensation is normal. So what do you think the patient is having? In fact, I was not knowing what this condition is. So I thought it's something akin to a Pari-Romberg syndrome, which affects the face. There is atrophy of the subcutaneous fat and the muscle. I was not knowing these conditions can occur in the arm. So that's I was not very sure what it is. So what do you want?
Focal atrophy of a muscle fiber. Part of biceps muscle is atrophy.
Yeah. It appeared like biceps muscle. That's what initially thought. So in fact, what I did was the conduction. The patient came with the conduction. Anyway, that was normal. That is first osteochondrosis, one fasciculation. That's totally unrelated probably. So I did MRI of the right arm. There was no atrophy of the muscles. There is gross atrophy of the subcutaneous fat. See that? Yeah, this is focal lipoatrophy. The muscles are normal muscle bulk, but there is no atrophy of the, atrophy of muscle, but the fat is tremendously atrophied.
Insulin can produce
Lipodystrophy, sir.
Pardon?
Lipodystrophy.
Yeah,
Insulin injection.
Yeah, as you said correctly, usually following injection, but she never had an injection. Following in the insulin and many of the drugs if you take, for example, your treatment, local injection for interferon beta, those things, if you go on taking it subcutaneously, you can have a lipoatrophy. So also classically insulin. And I also will describe in HIV patients can produce atrophy. So in fact, when we did the MRI of the arm, just screen the spine also, this is all normal. So the diagnosis is progressive lipoatrophy. No, I did not know about this condition. Radiologist only suggested this condition like that, and went in such literature. Lot of conditions are there producing lipoatrophy. Lot of many hereditary conditions, acquired conditions. So a few slides on lipoatrophy. Lipoatrophy refers specifically to specific loss of subcutaneous fat without exudative reaction or fibrosis. May be acquired or inherited. Acquired lipoatrophy may be further classified as generalized or partial. It may be HIV associated or localized. This condition called idiopathic localized involutional lipoatrophy is a rare distinctive form of localized lipoatrophy which arises spontaneously and is of unknown etiology. It is characterized by specific focal loss of adipose tissue without antecedent inflammation. Majority studies reported in literature have described inflammatory localized involutional hypertrophy with history of previous injections, drugs, or trauma. But this particular patient, some of them are idiopathic. This is literature showing this. Initially, there may be hyperpigmentation, subsequently, that may disappear. Only the atrophy may be left behind. This is another case of focal lipoatrophy, patient affected the lower limb. There's another condition called progressive lipoatrophy, where the patient that start from the face and go on to involve the rest of the body. Lipodystrophy syndromes represent a group of rare heterogeneous disorders characterized by progressive loss of fat tissue, mainly from the subcutaneous compartment and occasionally from the visceral fat also. Subcutaneous loss of fat can occur as generalized with partial lipodystrophy. Latter is more common. The onset is usually insidious with slow progressive disappearance of subcutaneous fat involved in the upper half of the body. The predictive progression of the disease from the face to the neck, upper extremities, and trunk, sparing the buttocks and lower limbs is characteristic. No specific cause or risk factor has been elucidated for progressive lipodystrophy. Some reports have shown a correlation with progressive lipodystrophy with prior acute viral bacterial infections. So these are the various progressive atrophies which they have lipoatrophy. They have given in the literature. Some limb confined to the upper limb like this. Lower limbs may be spared. And usually one type starts in the face, go on affecting the upper limb up to the buttocks. Usually the buttocks and lower limbs are spared. That is about that condition. So, any questions on that?
Sir, does she had any other vasculitic, this SLE, this?
No, in fact, I got a suspicion of scleroderma, but the dermatologist said there's no scleroderma changes, is not there in this patient. But otherwise, patient is asymptomatic 3 years. So I thought, why investigate? No other complaint. But even if you find something, they are we going to give steroid for this patient? Because totally, yeah, she has no other problem except the blouse is loose.
Yes.
Shall we stop or go for one more case?
One more case.
Sir, one
Does
more.
plastic surgery help?
I have no idea. Absolutely, I have no idea. Because I am seeing for the first time. But plastic surgery should help. Yeah, I don't know. Shall go for one more short case, okay?
Yes, sir.
This is a story of a 40-year-old lady. She noticed numbness of the right lower half of the face, lower half of right face, and right side of the tongue for the last 1 month. No other complaint. There was no pain. This is the patient's video. Ocular movements are all normal. Patient is normal. Masseter power normal. Lower normal. Femoral is normal. Is a decrease on the right frontal region, but sometimes on the forehead, mainly on the lower forehead.
നാക്ക് നീട്ട് ജസ്റ്റ് തുറക്കുക എന്ന് പറഞ്ഞ് നാക്ക് നീട്ടിക്ക് നാക്ക് അങ്ങോട്ടോട്ട് തള്ളിക്കുക ഇടത്തോട്ട് വലത്തോട്ട് മതി കഴുത്തങ്ങോട്ട് തള്ളിക്കുക ഈ വശത്തോട്ട് തള്ളിക്കുക ഇത് കേൾക്കാമല്ലോ ഇതോ കണ്ടുവരിക
Taking the sensation is pounding on the right upper face. He counted everywhere, but said it's less on the right lower face. There is decrease on the right tape.
വ്യത്യാസം മാറി നോർമൽ
That's when it become normal.
നോർമൽ എവിടെ പറയണം
Is it become normal there?
ഇനി ഈ കുത്തുന്നതും ഇതും എങ്ങനെയാണ്
There is decrease on the maxillary area also.
ഇത് മാറി നോർമൽ ആവുമ്പോൾ പറയണം
There become normal.
ഇതും ഇതും എങ്ങനെയാണ്
ഇവിടെയാണ് കൂടുതൽ അറിയാൻ പറ്റുന്നത്.
ഇതിന് വ്യത്യാസമുണ്ടെന്നല്ലേ പറഞ്ഞു
He said not much difference, but almost normal. So mainly, maybe V1 is affected by mainly V3, less so V2. On examination, rest of the slide, there is no long term signs in this patient. Decreased pain over V1 to V3, maximum over V3. No motor fifth nerve affection. Rest of the kindness normal. Rest of the CNS examination normal. So what is the likely diagnosis? Cytophelia, all of you know.
Jogrens.
Pardon? Jogrens. Right. So mononuria is the right fifth nerve, predominantly of the sensory. Most of the cases which I have seen is post-viral, and they remain like that for some time and improve. Some they do not improve, but numbness persists. They do not involve the motor part, sense remain for a long period of time. All of the investigations are usually normal. Others has already told, maybe a celly, Jogrens, vaginous granulomatosis, arcoid, all can produce. And infiltrated lesions like neural lymphoma and all. So what investigation do you want? MRI, okay. So let's see the MRI. This is the flare sequence showing hyperintensity in the mandibular division. This is the mandibular division of the fifth nerve. Again, you can find hyperintensity at the entry zone of the fifth nerve and also in the proximal part of the fifth nerve. The proximal part of the fifth nerve. Which is there. That's the brain normal. Again, I'll show the T2 weighted. Again, I'll stop here and just I'll show once again. Okay. See, there is the hyperintensity at the origin of that. The area where fifth nerve is entering, that area is hyperintense. I'll go forward. Exit of the fifth nerve. And this is the area that mandibular division again becomes, if it's enlarged, that part is enlarged. It's compared to that of that is enlarged. This again you can find the enlargement of the right mandibular nerve. Again, hyperintensity at the entry exit zone of the fifth nerve. This again flare sequence. This hyperintensity there, also the nerve, the fifth nerve, proximal part. Again, make it out the hyperintensity. This is the again hyperintensity in the mandibular division. This is a sagittal cut. This is the area of the fifth nerve going anteriorly on the affected side. This is the normal side. That is the affected side. Again showing the right, the affected nerve here and the unaffected nerve here. This is the digital coronal cut showing the hits on showing the icon. Contrast is a very subtle contrast enhancement, but not definite contrast enhancement. In fact, that's a subtle contrast enhancement, see things, very subtle. This sequence was not helpful, not see any abnormality. Rest of spinal cord normal. So T2 for hypertension in the root entries on the fifth nerve as well as the nerve with mild contrast enhancement. So what else you need? So we know there is some inflammatory change occurring in the nerve.
Yes, sir. Yes, sir.
Yeah. So did this SSP was positive, besides of Sjogren's syndrome. CT chest abdomen normal, CSO was normal. So what do you want to do now?
Steroids.
Yeah. In fact, I'm putting only short course of steroid only. She improved remarkably well. Whether it is that SSP antibody is significant, I do not know. Because many cases I have seen with the idiopathic, they improve with short course of steroid. They don't require long-term steroid as in the case of this one. It's only positive 1+. How far significance should be given? No. She has no other features of any other disease, only except this numbness. So she came for follow-up after 3 weeks. It was remarkable improvement. But still complained of paresthesia, but she's much better now. She's very happy. So this is the most likely. Personally, I feel more likely idiopathic post-viral neuritis.
Can it be something like the Tolosa Hunt?
We cannot call it Tolosa Hunt. By definition, Tolosa Hunt is a lesion is superior orbital fissure syndrome affecting the 3, 4, 6 and P1, and sometimes rarely V2. So this is entirely different. It's only mononeural is the fifth nerve. Fifth nerve affection can occur, as already told, Sjogren's, SLE, some drugs like drugs can cause beginner's endomatosis, sarcoid, neuroendophomatosis, neurolymphoma. These are the common causes. Idiopathic vacuum meningitis.
One doubt, sir.
Yeah, please.
Sir, why the motor is not involved? V3 division.
I don't know. That usually, this kind of a post-viral neuritis, sometimes affect only one part of the nerve. For example, if the commonest cause of vertigo is what? Vestibular neuritis. But it does not affect the cochlear part. Vestibular cochlear is only affect the vestibular neuritis. Some selectivity is there for some virus to affect. So something similarly, most of the sensory fifth nerve involvement, they don't affect the motor. The dictum is that if the motor is also affected, always think there is a tumor or something like that.
Okay, sir.
It's not that idiopathy cannot affect motor, but motor is affected, always very, very sinister cause you have to think. Either some fungal lesion or some tumor you have to keep in mind. These sort of idiopathic cases, like Sjogren, things like they are affected more of sensory than motor. I don't know the reason.
Okay.
Root entry zone is involved, sir, here.
Yeah, correct. Yeah.
Nerve.
Yeah, in the exit, within the root entry zone, the exit part and the nerve. And the whole end of the nerve up to the from an ovalis enhanced is affected.
Motor part is enhancing, but there is no motor involvement.
Motor, we do not know whether it's a motor part or not. Because
mandibular nerve is.
Mandibular nerve means motor nerve is different from the mandibular sensory. It may be confined only to the mandibular sensory division. Motor division is separate.
Okay.
Maybe the arrangement of fibers, sensory fibers.
We don't know. Some selectivity is there. That's the thing. Okay.
Okay, thank you, sir.
Thank you. We'll call it a day. Today, I know there's not much interesting cases are there, but anyway, much.
No, it's such interesting, sir. These are all interesting.
Like last time, I know there was challenging cases was there, no? Real mind-breaking cases, but this time only little more straightforward cases. Okay, thank you all. See
Thank
you.
you.
Thank you.
Yes, thank you, sir. Thank you, sir. Thank you.
Thank you all. Thank you.